Our goal today is really to introduce you to the APOL1 Roadmap if you're not already familiar with it. And for those of you who are, we really want to focus on how we can all increase awareness and understanding of APOL1 kidney disease among healthcare professionals, researchers, and most importantly, the affected communities in order to allow them and empower them to have the information and ability to make the best decisions for themselves and their families. So to get there, we'll discuss the complexities of this condition and explore some ways we can empower everyone here to use the APOL1 roadmap to determine which action items they or their organizations can complete to meet this goal. Next slide. Great, thanks. So for those of you not familiar with the Kidney Health Initiative, it's a public-private partnership among more than 80 organizations, including the ASN and FDA, that essentially a few years ago, as part of one of the projects that was identified as being important, brought together a group of kidney health stakeholders to analyze the landscape and create a comprehensive roadmap for how we get from where we are today to where we need to be to better manage APOL1 kidney disease. To do this, 4 work groups were formed with experts really focusing on 3 different core areas: education and awareness, genetic testing and counseling, and clinical study participation. And this work resulted in a roadmap outlining more than 40 action items focused around those 3 key areas, and also kind of organizing them by short, medium, and long-term goals. And so today we're going to talk a bit more about what this roadmap is, and then see some examples of why it's important to continue to work on ways to, again, change the ecosystem from where we are to where we need to be for patients and their families with APOL1. So this roadmap really highlights that it's not a very well-known condition, and because of that, and because of the broad range of people who could be affected, it leverages the socio-ecological model to really emphasize the interconnectedness of all of the various system components that influence health outcomes. So from government and policy to communities to individual households and obviously individuals, but also all of the factors related to the healthcare delivery system. This roadmap is really a collaborative effort involving experts from nephrology, clinical trials, patient advocacy groups, health equity organizations, genetic counseling groups, as well as people focused on developing new therapies for APOL1 kidney disease. It acknowledges the efforts, extensive efforts by various patient advocacy groups, some efforts by pharmaceutical companies, as well as other organizations who are trying to work on not only APOL1 kidney disease, but also broader disparities in chronic kidney disease. And so from this collaboration, the roadmap was really created to serve as a resource for many individuals and organizations represented here today. And with that, we can dive into a little bit more about what APOL1 really is. So next slide. So many of you are obviously here and familiar with APOL1 kidney disease, but just to set the stage for some common understanding, and you're going to hear a lot more of this background from Dr. Barry Freedman, but also personal experiences advocating for broader awareness by Nichole Jefferson in a few minutes. So APOL1 kidney disease is a genetic condition that affects people who carry high-risk APOL1 gene variants. And most people who are affected or have these variants are of African ancestry. African Americans in the US, you may know, represent about 13% of the US population, but disproportionately are represented in people who develop kidney failure and are on treatments like dialysis. And a substantial number of these people who reach kidney failure do have the high-risk APOL1 variants. In non-diabetic CKD settings, up to 50% of African Americans have the high-risk APOL1 variants, identifying, that this is a really high risk, potentially high risk condition. And APOL1 high risk variants may account for sort of much of the increased burden of kidney disease we see among those of African ancestry broadly. Most patients with APOL1 kidney disease actually experience earlier onset of kidney disease well before the age of 50. And often they don't know they have kidney disease until it reaches sort of very advanced stages because of its asymptomatic nature early on. Currently, there are no approved therapies for treating APOL1 kidney disease, but there's some promising therapies in the pipeline. And I see that a number of groups represented here today are leading the charge to help bring those treatments to patients soon. Next slide. So what's the problem that we're really trying to address? And I guess with this context of having a potentially very impactful, high risk predisposition to getting kidney disease with a variety of barriers that already exist in the healthcare system and the impending arrival of various therapies, it becomes really important to figure out where we are in terms of just broad awareness of APOL1 kidney disease. And some work by Barry Freedman and colleagues represented here on the call today that occurred a few years ago brought together a number of different stakeholders to sort of ask, hey, what's the level of awareness right now of APOL1? And among various key stakeholders, regulators, payers, policymakers, healthcare professionals, it really was quite low. Not only that, in the broader community who may be affected, it's also low. This was a few years ago. Obviously, things are getting better, and there's some wonderful efforts you'll hear about today that are helping to change that. But this highlighted that there's a really long way to go in raising awareness in order to, once therapies are ready, to get them to people, if and when it makes sense for them. I think one of the other things that we also recognize is that APOL1 kidney disease is something we're still learning a lot about, and Dr. Freedman will share some of his insights there with you today. Next slide. So as we described broadly, the goal of the roadmap really has three real key goals. The first is to increase APOL1 kidney disease awareness. And then the second is to increase access and awareness about genetic testing and counseling. And then the last is, really empowering patients to make informed decisions regarding currently clinical trials participation, and eventually deciding whether or not, once those therapies are available, whether or not that's the right decision for them or their family members. There's a number of challenges that we have to overcome in order to, essentially achieve all of these different goals. Each of these goals has been set in place to target unique challenges that have been identified and we've seen in the past. These have to be tackled to essentially be effective. And some of these challenges really include low health literacy, systemic mistrust, a lack of provider awareness, and limited access to testing. So these goals collectively really aim to drive the meaningful change in health equity for individuals of African ancestry who are disproportionately affected by APOL1 kidney disease. Next slide. And one more. Okay, so today's webinar is going to focus just on this first goal. How do we increase APOL1 kidney disease awareness? And we described just now, that some of the big challenges are low health literacy, which may contribute to a lack of understanding of chronic kidney disease broadly, might lead to misconceptions and stigma around disease. People of African ancestry may be more likely to mistrust the healthcare community and receive suboptimal care due to a variety of factors, including systemic racism, discrimination, and other structural characteristics of our healthcare system. And APOL1 kidney disease is currently underdiagnosed, period, due to insufficient education about CKD screening and diagnosis. So to overcome this, the solutions that were identified are really pretty obvious here. Education engagement and training. And so while there are a number of different action items in the roadmap that highlight the importance of this, there's really, these are the ones that are really important to sort of progress on a more rapid timeline. Without this, these are really enabling for everything else. So it's important that we get this right. So what could we do? Well, focused educational efforts, could include a variety of things like developing, disseminating, and leveraging existing infrastructure already in place to raise awareness about chronic kidney disease, broaden that to APOL1 kidney disease. These resources should, obviously be culturally inclusive, patient-centered. We'll hear a little bit more about how one group has been able to really do that effectively in one setting of sort of the spectrum of kidney disease. They should also include resources on clinical studies, and tools for managing APOL1 kidney disease. Prior to having approved therapies, there's still things that people can do to reduce their risk of progressing to kidney failure. So that's action one. We'll get into some of the letters here later. Another action is to lead, advocate for, and support the creation of an ICD-10 code. This is something that I'm very proud to say the community has done. A number of folks on this call were instrumental in that effort. Still waiting to hear the final outcome, but very promising effort to sort of have that be kicked off early on in the healthcare system. Diagnostic codes that physicians and payers use is important for identification and understanding how to improve care. The next and a really widespread issue across all of healthcare, but also particularly for this condition, is to really engage and build trust and empower people. So promoting awareness and activism among organizations embedded in African communities of African ancestry is important. This is really critical to addressing mistrust of the healthcare system that exists pretty broadly, and getting community leaders involved while using existing infrastructure to support these sort of ways of engaging on a more long-term basis is critical. And then finally, but not least important, is that of provider training. And this is where a number of different groups are, there's some better positioned than others, but incorporating training about diagnosis, management of not, rare diseases broadly, but also APOL1 kidney disease, and obviously genetic kidney diseases broadly, but specifically APOL1 is really important. Next slide. So again, we spoke about some of these challenges. This is just summarizing that across this first goal, there's a number of key challenges to overcome. All of this is going to be important, and important to sort of reflect how we overcome these challenges in the various materials and ways of communicating the information that people need. Next slide. And then we talked about education and awareness broadly. It's not just about disseminating, but we're going to need to engage communities across multiple different settings over time. And then importantly, there's a big training component here that's important for everybody, but including providers. So the next slide highlights what these action items really look like. So I mentioned at the beginning, the roadmap has over 40 action items, sort of tiered by things that can be addressed on the short, medium, and long term. And this is really just sharing some of those specific action items across the domains we just discussed. So the next slide is really just highlighting that, it's going to take all of us together. So it's, not only healthcare providers, but it's also patient advocacy groups, community organizations, and as well as policymakers that are going to be important in sustaining and supporting the initiatives to improve access, promote health equity. All of this is predicated on raising awareness about APOL1 kidney disease. So with that, I'm going to actually turn it over to our next speaker. So Next slide. It's really my pleasure to introduce Nichole Jefferson, who is a passionate and dedicated kidney warrior. She serves on multiple advisory boards and committees, and she's going to share some of her insights while co-leading the NIH Apollo Community Advisory Board. Turn it over to you, Nichole.
Thank you, Dr. Patel, for such a warm and welcome, and for that extremely good information regarding the roadmap. Just to tell everyone a little bit about myself, so you can see how important the APOL1 gene is to me. Every day from 9 to 5, I'm a corporate risk manager for a large financial institution. I'm president of Home Dialyzers United, and 1 to 2 days a week, I do teach ASL to hearing children. Additionally, I spend about 40 hours a week being a kidney advocate for patients and myself, but 24 hours a day, I'm a transplant recipient, having received 2 transplants, the most recent one being in April of 2020. Next slide. And here are a few of my disclosures. And I want to go ahead and point out that I was a part of the inaugural steering committee of the APOL1 Long-Term Kidney Transplantation Outcomes Consortium. Next slide. The roadmap. As Dr. Patel discussed, there are 3 goals of the roadmap: increase awareness of APOL1 kidney disease, increase access and awareness of genetic testing, and empower patients to make informed decisions. Of course, we're talking about goal 1 today, and the action items are listed below. Focused educational efforts to increase awareness, engagement to build power, empower and trust, and provider training. When I was asked to join the Apollo group, of course, I automatically thought about Tuskegee, like most of the times we do. I also thought about Henrietta Lacks, like we do a lot of times. But in addition to that, I thought about the cases that are not well known, the cases that are near and dear to me. I think about Dr. Patrick G., who was seeing an endocrinologist for 10 years, who never brought up the fact that kidney disease was in his future. I think about another friend of mine, Curtis Warfield, who was told he could go on prednisone and everything would be okay, who then went into kidney failure. I also think about myself, who went to see a doctor, my primary care physician, exactly 1 week before I crashed into dialysis. And with that, I thought about the mistrust that I have, as well as other people. And so I felt it was my moral obligation to make sure that the Apollo study was done right, that we had awareness to people who look like me and the providers to understand what's going on. Next slide. So as I stated, this is what Apollo stands for, and it's funded by the NIH, as Dr. Patel stated. And what it involves genetic testing of biospecimens for APOL1 gene variants. Inclusion criteria, these are the things that we include for this study. Deceased kidney donors and living donors with recent African ancestry, or Black donors. But what does that look like? That's something that we've also had to focus on, making people aware, not only what you think you are, but what you actually are, which can lead to other forms of distrust as well. And also all recipients of those transplanted kidneys. We're tracking outcomes among racially diverse kidney recipients who receive kidneys from Black donors. The goal of the study is to support changing the KDRI formula. And what that is to remove Black in that formula and replace it with APOL1 risk. And also to reduce the discard of good quality deceased donor kidneys. Next slide. So the role of the advisory committee, the CAC, the Community Advisory Council, is essential to the study. We represent people living with various stages of kidney disease and living donors. We actually have had 2 people on the study who were living donors as well as transplant recipients. Each gave to their mother and in turn needed a kidney later. And those people have been pivotal in explaining how they feel or how things work to make this study easier. One of those participants has actually done a study on next of kin. And what we've done to help with awareness is we've helped shape the study protocols, consent forms, and making sure that the consent forms are easy to understand for the everyday general patient. Also making sure that patient-facing material is easy to read. And as Kevin Fowler always says, we are the voice of the patient. Next slide. We do have a couple of problems and concerns in this, and these have been addressed by the group. One of them is racially targeting research that raises ethical and transparency concerns. And so what we've done for awareness is we've tried to make sure that we are making people aware of the gene and everything that entails so people won't have issues, and making sure that everything is up front. And with this, we always make sure that Apollo makes sure that they put the patient at the center of it. One of the ways that they've done this is at the very first meeting when we met. Uh, of course, everyone was at the table, but Dr. Kimmel made sure that everyone was removed from the table and only the patients were there to make sure that the researchers understood and doctors realized that the patient is the center of this research. Additionally, Dr. Freedman has been very good in one question he had. He stopped the meeting and came to ask the patients for their feelings and concerns about a particular issue. So that's been going on. So the way that we address the educational efforts to increase awareness, there's a patient on every committee that the Apollo group has. So we have the publications, recruitment, steering committee, and dissemination. So dissemination is ways to get this information out. And we've had various ways to get the information out to people. And with that, we're telling, when to tell people about the study, how to tell people about the study, making sure that everything is easy to understand. We look for ways to get the word out at all times. We've done plenty of articles that have been disseminated everywhere. We've had webinars with the American Association of Kidney Patients. We've had a Facebook Live event with NKF. We are also looking for we're actively looking for new ways to engage and to provide this awareness. Currently, we're working on a manuscript, we're working on a video. We do have a next of kin video, as I've stated. We have a FAQ, and we do have a website. These are ways in which we provide awareness to the broader community. And also with the next of kin video, we wanted to make sure that when this study is being explained by the doctors, by the researchers, that they understand that someone who looks like them is actually sitting at the table to make sure that everything is done right, or at least the way we think things should be. And so those videos uh, help make the person understand what they're getting into and everything that's going on. We also have videos for the providers as well to make sure that they're trained and they understand things from the patient point of view. Um, as I've stated, we've partnered with patient organizations and other organizations, and we actively engage with the Black community. And what we do, as Dr. Patel stated, we're going out to the communities, but we're also making sure that we're returning results and making sure that they are up to date with everything that's going on. Not just going to the community and saying, hey, we need you, but the end result is to make sure that we are giving this information to them once everything is complete with the study. So we've been doing a good job of that. If you look at our website, apollocommunity.net, that's for the general public, but it also gives plenty of resources, the resources um, that we've helped make to give information about the APOL1 gene to bring awareness to everyone. And as far as engagement and trust, the engagement and trust comes in with those videos. It comes in, by us being a part of, shaping the policies and the guidelines and things like that. One of the things when we want to make sure that we're in doing the trust and empower, a lot of times people feel that the patient advocate automatically has this trust for the medical community. So we had to make sure that even, the patients on here trusted, had, felt empowered to go about this study. Next slide. So we're all over social media because we want to make sure that people understand this. Not only understanding APOL1, but also understanding kidney disease. Because as I stated earlier, a lot of people don't even understand that if they have high blood pressure, if they have diabetes, they're at a high risk of kidney disease. So we have to go back to the basics and then bring in uh, APOL1 gene and different things like that to make people aware that these are additional things that can go on. Next slide. So that's actually going into berries. But as a patient advocate, we make it our mission to go around and to make sure we are spreading awareness and making sure that everyone is aware of the roadmap of the gene and how to empower themselves. Thank you.
Great. Thanks so much, Nichole. Really appreciate you sharing your personal journey, your insights, but also your experience from Apollo and highlighting, how, what good looks like, but what it took to make good, really keeping patients at the center throughout not only the engagement, but also, like you described, behind the scenes, that it was meaningful and continuous throughout from beginning to end. So thank you very much for sharing that. I think we have a poll now that the audience will receive. So I can't see what you're going to get. So over to Alea. Okay. So do you or your company have any efforts that focus on education and awareness of APOL1? If so, please share some of those experiences in the chat. Okay, wonderful. So 2/3 of you are actively involved in some efforts. That's fantastic. The goal of this webinar is really to bring folks together across the range of activities, thinking about it to actively doing it. And we'd love to hear about some of those efforts that are going well, some lessons, whatever you can share would be wonderful for us to start to learn more as an organization, as a community, with this shared goal. So Nichole, you mentioned returning information to patients, and Glenda just shared that in the Kidney Precision Medicine Project, one of the really important goals is to return genetic information and results back to study participants if they, regardless of their test results. So I think that's wonderful. How important has that been in the efforts that you guys have had with Apollo?
Uh, it's been about the same. However, it'll be more than likely at the end. I work with Glenda on on KPMP as well, and that has been a very big part of KPMP. However, I do believe it'll be toward the end of Apollo that we're going to be able to actually return the result to to the to the broader community.
Great, thank you. Would love to hear from more of you out there.
Dr. Patel, while we are doing that, I just wanted to bring up. So with Wells Fargo, we have a Black African American connection, and I have provided information to that group regarding kidney failure, but I also discussed the APOL1 gene. And so after that, I did have a lot of people reach out to me asking how they could be tested for this or different things. I actually had two people come to me and say they had gone and gotten tested for, kidney disease in general, just asking for a check, and they had been referred to a nephrologist due to the information.
That's awesome. So I love how you're not only a champion nationally with all of these efforts, but also locally during your day job at your place of employment and making a big difference there. So that's a great example of how we all might be able to find creative ways, at every level of where we act in our communities to engage. Thanks, Barb, for putting in and highlighting what NephCure has done. NephCure has really been doing some wonderful work to raise awareness about APOL1 kidney disease. And you highlighted that in the fall, September of 2023, there was a very unique meeting that was a very broad, inclusive group of people that I know that there was also some sharing of those experiences with people in DC and some of our lawmakers. So that was very impactful. I hope people are able to connect to some of the materials that came from that and some of the recordings. But I know it involved church leaders, folks, typically not involved on the provider side, but also a broad range of people to draw more people in, particularly young people, when you've got folks who are in the entertainment or sports industries as role models to raise awareness. And thanks. I can't see who put in the comment for Vertex, but they've also done some fantastic work. Got a healthcare focused website, which is wonderful. Encourage everybody to check that out, as well as a community focused website. These are important efforts to raise awareness for sure. And Rihanna's added some more information from NEFCure. Working at historically Black churches and universities. Obviously, that's incredibly important to go build those relationships in the community. And more events planned in the fall, which is great. And it would be wonderful to get as many people involved as possible. Yeah, and Barb also added the APOL1 Kidney Disease Awareness Day. That was fantastic. AKF and others, Vertex, everybody was involved, NEFCure. And then Mark has asked, maybe the group, are there any examples of raising awareness in communities of multi or mixed ethnicities where there might be significant risk of APOL1? And I'm reading between the lines for Mark's question here, but people may not recognize that they're at risk.
Dr. Patel, can I speak to that really
Oh,
quick?
please.
So I wanted to bring up, I think that's very important what Dr. Lim brings up. At the Codigo study, we did discuss Brazil, and there was a study done in Brazil in which a lot of people didn't identify as African American, but they did have the variant. It was like 40%. So I do think it's important that we try to figure out, who do we test? Do we test based on visual? Do we test based on self-identification? How do we decide who's Black, who has recent African ancestry? Because what we think may not be true.
Thank you. Very powerful example and important. And this is a work in progress for the community. As genetic testing broadly for kidney diseases becomes more available and accessible and more actionable, I think testing people with kidney disease is one way to potentially not have to do the guessing game of what's someone's ancestry and could they have APOL1 kidney disease. I don't know if we know about the best practice there, but it is something that's important to consider. So a bunch of wonderful comments. 23andMe, Vertex efforts, but also Glenda highlighting that specifically communities that have been included have not only been African American communities, but also Latino and Afro-Caribbean. Good. Well, maybe encourage people to continue maybe adding their experience there. But we're gonna move on to the next presentation. I really appreciate everybody's active participation, but very pleased to introduce Dr. Barry Freedman, who's a distinguished clinician scientist in nephrology. He's a humanistic leader. I've known him for decades, passionate advocate for patients with kidney diseases. He's an endowed professor of medicine and chief of nephrology at Wake Forest University School of Medicine. He studies genes that cause complex kidney and cardiovascular disease, diabetes, and population-based disparities in the genetics of population-based disparities that put people at risk for kidney diseases. His work on studying African American families with end-stage kidney disease paved the way for identifying various major risk variants, including APOL1, and now his team is really working on understanding various aspects mechanistically and epidemiologically of APOL1 associated kidney disease. So we're lucky to have Dr. Barry Freedman here. Turn it over to you, Barry.
Thank you so much, Uptal, and thank you, Nichole, for the fascinating start to this meeting. It's a pleasure for me to speak about the NIH Apollo study as part of this APOL1 roadmap. I'm going to go through some of the science of APOL1 and the Apollo study, and I'll try and focus on education during my talk and at the end. If I could have the next slide. please. Thank you. This is my disclosure slide. You can advance further. Thank you. So in 2010, discovery of the APOL1 gene was reported in the journal Science. And, I have to say that in the early 90s, I was convinced that there was a genetic predisposition to kidney disease in African-American families. They had often had multiple members on dialysis, and we started collecting DNA samples, 30 years prior, or 20 years prior to this breakthrough. One of the things that drove us was that there were many different kidney diseases in single African-American families, something we just didn't see in other populations. So collecting DNA, and as genetic technologies evolved through the years, it led to this fantastic paper with Martin Pollack, Jeffrey Kopp, and our Wake Forest group on the APOL1 association with kidney disease. If you have two risk variants, one inherited from your mother, one from your father, and also protection from African sleeping sickness. And we'll point out that not everyone with two risk variants gets kidney disease, although the risk is markedly increased. Next slide, please. This went to define why we saw many different forms of kidney disease in single African-American families in the early 1990s. And, FSGS, focal segmental glomerulosclerosis, collapsing FSGS, whether it's due to HIV infection, COVID infection, administration of interferon, or even unknown causes of collapsing FSGS, they're considered the hallmark of APOL1 nephropathy. But this disease, solidified glomerulosclerosis with very low levels of proteinuria, is clearly in this family, and it's often been misdiagnosed as hypertensive kidney failure. And we all know now that lowering blood pressure in African Americans with presumed hypertensive nephropathy using ACE inhibitors, high-dose ACE inhibitors, none of these things have really protected. And the APOL1 gene discovery described why. It's a primary kidney disease not due to high blood pressure, the high blood pressure secondary. Sickle cell nephropathy, lupus nephritis, and failure of donated kidneys from deceased African-American donors with two APOL1 risk variants all fall within this spectrum and define why we saw many different causes of kidney disease in single families. Next slide. I just want to point out that the APOL1 discovery is the single strongest genetic association in any complex common human disease. And it's no longer an association, it's causation. APOL1 causes more than a third of end-stage kidney disease in African Americans. I'm from New York. I work in North Carolina. But if you walk into any dialysis unit in the nation, from Los Angeles to Birmingham, Alabama, to Chicago, to Brooklyn, to Winston-Salem, 1 out of every 3 patients with recent African ancestry on dialysis, regardless of what the diagnosed cause of kidney failure is, are on dialysis relative to the APOL1 gene. 13% of African Americans have inherited 2 copies of risk variants, placing them at higher risk for kidney disease. That's more than 5 million people. 39% have 1 copy, capable of transmitting that to their offspring. And if the offspring get 2 copies, that puts them at risk. And 48% have no risk variants. So 52% have 1 or 2 copies of APOL1 risk variants in African Americans today. Think about the fact that those 2 risk variants, G1 and G2, were not present in anybody on Earth 8,000 years ago. These are new variants, and they're so protective from African sleeping sickness, we think millions died off because they didn't have these variants. When the variants suddenly appeared 8,000 years ago as new mutations that supported survival from African sleeping sickness, and they were rapidly transmitted to where more than half of African Americans have at least 1 risk variant today. These risk variants are virtually absent in European, Asian, and purely Hispanic populations, although Hispanic populations that are admixed with African American populations, Puerto Rican populations, Dominican populations in the Northeast, they certainly possess APOL1 risk variants, but it came from the African ancestry. 70% of cases of FSGS and HIV-associated nephropathy in African Americans would not exist if it were not for the APOL1 gene variants. In fact, if the G1 and G2 variants didn't come about, the risk for non-diabetic kidney disease in Blacks and whites in the United States would approach unity. This nearly 3-fold or 4-fold excess risk is in large part attributable to these risk variants. And the APOL1 gene's only found in humans, gorillas, and baboons. I can just tell this audience that all the grants we wrote for years and years that were rejected because somebody had a better rodent model, rat model, mouse model of kidney disease than humans, they couldn't find the APOL1 gene because mice and rats don't have the gene. So it's been a long story, and I'm very pleased we are where we are today. Next slide. So, there are now potential clinical benefits of genetic screening for APOL1 in individuals with recent African ancestry. I'm going to focus on the transplant living kidney donor candidates and deceased kidney donors, but just to point out that now that we have novel therapies in clinical trials, APOL1 small molecule inhibitors, inhibitors of pathways involved with APOL1, and APOL1 antisense oligonucleotides, patients with chronic kidney disease, diabetic and non-diabetic, will benefit from genetic screening to see if they're eligible for these trials. Patients with HIV infection, lupus, sickle cell disease, they may benefit if they want to know if they're at increased risk for kidney disease or if there are compliance issues with their basic therapy and clinicians want to get additional ammunition to encourage them to be compliant, and for family planning purposes. So it's a new age. And, now that we have clinical trials underway and the promise of novel therapies, I believe APOL1 screening is going to become widespread and education is critical. Next slide. So I'm going to turn it over to the Apollo study now. Nichole spoke about this, the APOL1 Long-Term Kidney Transplantation Outcomes Consortium. I'm one of the principal investigators. Wake Forest is the coordinating center. And I just want to say the Community Advisory Council in Apollo has been critical to every effort of this study. There are internationally renowned experts on the Community Council. Nichole Jefferson, Glenda Roberts, Patrick G. ASN Medal Award winners are on our very dedicated Community Advisory Council with other experts in the field. And they've guided the scientists on this study since inception, as I'll point out, and they're critical to disseminating knowledge into the African American community. Next slide, please. So the goals of Apollo are that, retrospective data have shown that deceased donor APOL1 genotypes associate with more rapid graft failure after transplantation. And retrospective data suggests that after living kidney donation from African Americans, APOL1 is predictive of poorer long-term outcomes in the living donor. I'm going to show you this data, but there's no prospective data. And the American Society of Transplantation demanded prospective data. So the NIH went ahead and funded Apollo to repeat all the retrospective findings and see if we could show it in a prospective fashion. So it's addressing donor and recipient APOL1 genotypes as predictors of earlier kidney transplant failure and kidney functional outcomes in recipients, and on post-kidney donation kidney function, proteinuria, and vital status in living kidney donors. All donors are of African ancestry. Next slide. This is a long slide of the Apollo organizational chart, but I just want to say that basically the whole nation's, this is the largest kidney transplant study with biosamples ever done by the OPTN. The networks that are involved, 1 to 13, involve Wisconsin, Vanderbilt, Hopkins, UAB, Columbia, Mount Sinai, Cleveland Clinic, Emory, Boston, Maryland, Miami, UCSF, and Wake Forest. Wake Forest is also the coordinating center, and we work with the United Network for Organ Sharing, AOPO, and all 58 organ procurement organizations, the American Society for Histocompatibility and Immunogenetics, the NIDDK Biorepository, and the NIH Community Advisory Council, and an external expert panel. Every transplant program in the nation has been contacted, asked to participate in Apollo. More than 140 transplant programs have enrolled participants from their centers in Apollo. This is a wide-ranging national study that's got the intention of the transplant community. Next slide. So we think APOL1 genotyping is going to revolutionize kidney transplantation. Many transplant programs now perform APOL1 genotyping in African ancestry living kidney donor candidates before they'll do a donor nephrectomy to know if a young African-American potential living donor has a high-risk genotype, which certainly requires a discussion and maybe consideration of alternative donors. So the NIH Apollo Consortium is assessing APOL1 in deceased donor and living donor kidney transplant, with the potential to better define deceased donor organ quality, which could change allocation, improve the matching of donors and recipients, leading to longer graft function, reducing discard of very good quality kidneys that are currently underrated and rated as worse than they are by the current guidance. This would yield more kidney transplants and make living donations safer. Next slide. And the outcomes of Apollo are time to death-censored kidney allograft failure based on the number of deceased donor APOL1 risk variants. Secondary outcomes are the rate of loss of GFR, rate of change in serum creatinine, time to sustained overt proteinuria, and to assess the role of recipient APOL1 interactions with the donor APOL1 genotype. So this is all being done prospectively, and unfortunately, the pandemic kind of got in the way of things. Next slide. This is the background on which Apollo is based. This is an early study just showing that these are deceased donor kidney transplant outcomes. And if you look at the two curves, if it was the donor was of African ancestry, those kidney transplants failed much more rapidly than a deceased donor kidney transplant from donors of other races other than African American. And nobody understood why this occurred when it was reported, but it was widely observed, had nothing to do with the ancestry of the recipient. It was all based on the donor ancestry. Next slide. Once APOL1 was discovered in 2010, our group looked at the Wake Forest data in a single center study of 136 transplants, all from African American deceased donors, and we saw that clear separation. If the African American deceased donor had an APOL1 high-risk genotype shown in red, those grafts failed very quickly. But if it was an African American deceased donor transplant from a donor with a non-high-risk genotype, only 0 or 1 APOL1 risk variants, those kidneys did just as well as kidneys from European donors. They did not fail rapidly. I'll just remind you guys, this paper was initially rejected by the American Journal of Transplantation. It was reconsidered, finally accepted, and it's been referenced well more than 300 times and led to the Apollo Consortium, a $50 million, 12-year consortium trying to study this issue. Next slide. We were dinged that this was a single center study. We expanded to 1,153 transplants, 624 different deceased donors, all African ancestry, from 113 transplant programs. And we saw the same thing, a more rapid failure of kidney transplants from African-American deceased donors with high-risk genotypes compared to African-Americans with low-risk genotypes. This means it's not African-American race or ancestry that defines the poor outcome. It's the biologic change induced by an APOL1 high-risk genotype. I'll also point out that the majority of recipients of APOL1 high-risk genotype kidneys didn't fail quickly and will function for long times. Those kidneys are perfectly usable, but we may want to consider which recipients get them, which is the allocation system. Next slide, please. So how are kidneys currently allocated? The Kidney Donor Risk Index, which Nichole mentioned. And the goal is to take the highest quality deceased donor kidneys and give them to the healthiest recipients. You don't want to take a very high quality kidney that could last 25 or 30 years and give it to a 70-year-old recipient with type 2 diabetes and amputation and prior coronary artery bypass surgery, because they're probably not going to live 25 years to get the benefit of that kidney. They could take a lower risk kidney, a lower quality kidney that will last as long as their expected lifetime. You want to save those great kidneys for young, healthy recipients who can get 25 or 30 years lifespan out of that kidney, do well, and go on and get another transplant if that were to fail. And the 10 factors that look at the quality of deceased donor kidneys, one of them is ethnicity, African-American race versus non-African-American, based on the study I showed you before that those kidneys fail more rapidly. Now, to the credit of the KDPI, it looks like ethnicity, the African-American race component, is soon to be removed from the Kidney Donor Risk Index. But I want to show you what this has done to the allocation of kidneys in the current era. Next slide, please. We published a paper getting rid of that donor race and replacing it with APOL1 genotype in those 1,153 transplants from 113 transplant programs. Next slide. If we look at those 1,153 transplants now, the KDPI Kidney Donor Profile Index is about 70% in all those African-American deceased donor kidneys, meaning those kidneys were expected to do worse after transplant than 70% of all the kidneys transplanted the year prior. That's based on the current KDPI/KDRI risk index that includes African American race right now. We replace that with APOL1 genotype. Next slide. And you can see that the group with the low risk genotype is not a 71% risk, it's 50%. Those are average kidneys. They do worse than 53% of all kidneys transplanted in the prior year. They are good quality, they're fine, and they're being downgraded by the race categorization. However, if you got one of the kidneys with two APOL1 risk variants, the kidney donor profile is not 70%, it's 88%. They're going to do worse than 88% of all kidneys transplanted in the prior year. So the bottom line is there's a tremendous change in allocation if you use APOL1 rather than race. And if you hit the next slide, you'll see how often this occurs. 87% of the time, the kidneys are getting much better. Only 13% of the time are they lower quality. So in fact, we'd be improving the rating of 87% of African-American deceased donor kidneys, reducing the chances of them being discarded because a surgeon or transplant team might assume they're lower quality. Next slide. And if we look at the effect of APOL1 genotypes in former living kidney donors that are African-American, this is a paper by Monadoshi, also in Apollo, 12-year follow-up of 136 African-American living kidney donors. Next slide. At baseline, these people were 37 years old. 19 of them, or 14% of the population, had an APOL1 high-risk genotype. This was done a long time ago, before APOL was known. Actually, 117 of them, 86%, were the low-risk genotype, just what you see in the general population. They're all 37 years old. The kidney function was pretty normal in all of them, but it's a little lower in the high-risk group, 98 mils per minute GFR before they donated versus 108 in the low-risk group. So the high-risk group have a slightly lower GFR, but it's in the normal range, and you wouldn't suspect there's anything wrong with that donor with a GFR in the normal range. Well, what happened 12 years later? Next slide. 12 years later, 2 of the 19 APOL1 high-risk genotype living donors had kidney failure themselves. They were healthy enough to donate, and within 12 years, they developed end-stage kidney disease and needed a transplant themselves. 2 of 19, or 11%. If we look at the low-risk group of 117 donors, none of them developed end-stage kidney disease. And if we look at the percent with a GFR less than 60, 2/3 had a GFR less than 60 of the high-risk donors. 12 years later, only 36% of the low risk. They're only 49 years old 12 years later. They have a long life ahead of them. So more kidney disease will develop. Next slide. I'm going to just wrap up to say that Apollo was targeted with getting 2,614 deceased donor kidney transplant pairs with an APOL1 genotype in the deceased donor and outcomes in UNOST in the recipient. We've actually got 6,835. We did 2.6 times the recruitment we were anticipating, and 2,704 recipient DNAs are collected to look at recipient genotype effects. Next slide. Finally, I'm going to end on this slide, Uptal, so you can jump in after this, but the fact is that APOL1 is already changing clinical practice. We don't even have the results yet. We think the genotyping will be done in 2024. We'll be returning results to those participants in Apollo who want them in 2025. The participant infographic for return of information was worked on by the Community Advisory Council. Frequently asked questions to answer questions that may come up were developed by the Apollo Community Advisory Council, and they reviewed our responses. The CAC has been just critical in how APOL1 results will be returned, but now the AST actually guideline group suggested APOL1 discussions be held with every African ancestry potential living kidney donor before a donor nephrectomy is done. So they go into living donation with the understanding that APOL1 exists, testing is available, and they could have testing done if they would like it. And next slide. We've also published practical guidelines, and my last slide follows. Next slide. And basically, we don't think every African-American living kidney donor candidate needs to be genotyped for APOL1. If they're going to be screened out early because of social factors, insurance problems, medical problems, they should be excluded, and they don't need to have a APOL1 gene testing. But if they pass the preliminary work and look like they may be a good quality living kidney donor, we strongly believe APOL1 genotyping should be discussed absolutely in young African ancestry, potential living donors such as child to parent or sibling to young sibling. We think it's very important. And high risk living donors, we should have a discussion at transplant programs as to whether they should be the candidate. So before Apollo even comes out, we're changing transplant medicine and educating the transplant world and patients. And Uptal, thank you so much for allowing me to participate.
Oh, thank you very much, Barry. This was great, and I think really highlights really the thoughtful work you and so many others have been doing for Apollo. And uh, at the end here, I mean, bringing it together, showing the impact it's making on how you actually make decisions moving forward. So great example. Um, thank you very much. I think we're going to have another poll question here. So while it pops up for everybody, I'm just going to read it. It's, which of the following challenges do you face most frequently? Please share any thoughts about those in the chat. So engaging the right audience, um, having your audience understand your message, or framing your message for the right audience. So no, there's a lot of experience out there, so look forward to everybody sharing that. Okay, awesome. So about 20% for engaging the right audience, half having the audience really understand the message, and then about a third framing the message for the right audiences. So this is really important, and one of the perennial challenges in public health efforts and education about disease awareness, particularly with all of the complexities and challenges we've discussed. So maybe just ask both of our panelists to kind of react to that poll. Does that resonate with your experience in Apollo?
I guess, in the poll, what was curious to me is understanding of the message. Can you put those numbers back up there? I think it was 50%. And I guess it caused pause as to if they don't understand the message, are they engaging the right audience? And are they framing the message for the right audiences? So I think that would be a good question. But the CAC has made sure that we're engaged, that the right audiences are engaged. And of course, in this situation, it's only one audience pretty much. And just framing the message. And we did by framing that those videos and the webinars, from people who are actually involved in the study. On the CAC, rather.
Thanks, Nichole.
Sorry, Nichole. I would say there are many different audiences to inform. And, one thing, the Apollo study has been quite transparent. We have published all of the protocol, the consent form, recruitment efforts, all the infographics that are shown to potential participants about being in the study, getting results back, risks and benefits are all published, widely available for any other study to use. So we've reached out to the medical world, and this Community Advisory Council, by the way, has published a paper in American Journal of Kidney Diseases that was written by the CAC, and many of the individual CAC members have published articles in the medical literature. All these websites that old guys like me don't know how to work, Twitter, X, all those things, Nichole is expert on, and Apollo and the Community Advisory Council have made sure to reach out to all those endeavors. But at the end of the day, I think it's critical that nephrologists and the patients know first, because once we get results from the clinical trials that are ongoing and from Apollo, we need to educate the general medical providers, primary care providers who are seeing patients early, so that if patients don't know, participants don't know, their general care providers know to get them to a specialist, get them evaluated, genotyped, get into a study or on treatment when these treatments are available.
Thanks so much. So you highlighted actually some subtlety. So because I think from the outside looking in, people might think, hey, talking about raising awareness in this transplant setting seems simple. It's a defined group of people. But Barry, you highlighted that actually there are multiple audiences, and you're absolutely right. There's all of the colleagues taking care of patients, the medical system side, but on the patient side, there's not only the individual patient, there's all of the members behind them, their family, their other supports. Tell us more about those different audiences, and in addition to the Community Advisory Council, how you were able to tailor messages, or how did you navigate that?
Well, so one thing I think it's very important, and I think Nichole alluded to this, is, whenever you're doing something with race charged messages in there, it's best to take it back a step and bring it, the bottom line is this is a biologic finding. And if there's a family that has multiple members with polycystic kidney disease, and you know the genetic basis in that family, and somebody's young and wants to donate, you test them for the autosomal dominant polycystic kidney disease variant. You say, hey, you could be a great donor. You don't have that variant. You're not going to get this disease in your lifetime. So one of the pushbacks we got is genotyping and discussing this is going to, African-American living donors are going to go down. There's going to be fewer of them. In fact, I believe it's the opposite. I think once people are reassured that although they have 5 members of their family on dialysis, the reason's APOL1 and they don't have a high risk genotype, so it is generally safer for them to be a living donor, that's really going to help. So I think we have to get the word. I mean, the transplant community has known early on APOL1 would have the first impact in clinical use. Then the clinical trials for treating native APOL1 nephropathy have come to fore. And all the general nephrologists had said, why would I test for this? There's nothing I can do. Now you can do something. Get your patient in a clinical trial. So, and that provides great hope for cure, more than lowering blood pressure, ACE inhibition, all the standard stuff we do, which we should do anyway. So I think that, there is a broad rollout of this. Transplant nephrologists, general nephrologists, and the transplant patient community are the first. Then getting it into the dialysis populations to spread the word. Finally, when we have treatments for native kidney disease, Nichole, I think the Community Advisory Council Dissemination Committee are going to attack primary care providers and make sure they get these people referred early before it's too late when treatments could be effective.
Thanks, Barry.
Right.
Nichole, do you have anything to add you want?
No, I was just going to say, right, I agree. One of the things with primary care physicians that we're trying to push is even making sure that their patients are aware. I find it shocking that even endocrinologists who deal with diabetes every day, they don't tell patients, oh, you may end up with kidney disease, or this is what happens if, this can happen if your diabetes is not controlled. So I think just pushing that message out to primary care physicians about everything that's available and all the things that could go wrong and may go wrong. Dr. Keisha Gibson gave an example, was telling me about a couple of patients she had who were young Black men. And, Black males, let me say they were about 12 years old and they had uncontrolled high blood pressure. She couldn't find a reason. So she tested for APOL1. That's something that we should be doing anyway. If you have things that you can't understand or you can't explain, especially with a young Black person as early as 12 having high blood pressure, we need to check for certain things. But a lot of doctors aren't doing that. They're just saying, I don't know, which unfortunately is what happened to me. I don't know.
Thank you, Nichole. Again, powerful personal anecdotes and important for changing things moving forward. So this was great. I want to highlight another thing that both of you did was say, hey, we've developed all this material for the Apollo study, but it's available and you can access it and take it and reshape it for your community, your organization, your population. And I think that's one of the goals of this webinar and our ongoing efforts is really for everybody to not have to start from scratch and reinvent the wheel, right? There's a lot of wonderful efforts. Many of you have put stuff in the chat, links to efforts that you or your organizations have been a part of. So please continue to do that. We want this to be a community effort to help with this pretty big challenge. So I'm going to transition a little bit to some discussion with both of you about what this might look like for some of our panel, our members of the webinar here, other participants here, and so inviting everybody to sort of contribute on chat, but we'll have a brief discussion. So outside of patient organizations, how else are people bringing increased awareness to those who are at risk for APOL1 kidney disease?
Nichole, I think some of the discussions that you and Dr. G and Glenda have had with barber shops to college campuses and sororities and fraternities might be appropriate here, Nichole.
Yes, we've been just going out speaking. One of the things that I do is anytime I hear of someone who has kidney disease, I automatically talk about APOL1. Right now in my community, the community in which I was raised, we have 4 people who are on the waiting list right now. So that's something that I'm discussing in my neighborhood face groups and different things like that. What's going on? Is it attributed to this? But also, we are doing talks. Patrick G and I did a talk along with Glenda on blackdoctors.org. It was a Facebook Live as well. So those are some of the things that we're doing outside of the Apollo study, but just making sure the word is out there.
Great, thank you.
And Uptal, I have to tell you that, I'm doing my longitudinal knowledge assessment to keep my board certification. And finally, APOL1 questions are on the boards. So we stopped calling this thing hypertensive kidney failure, which in the African-American population is a nebulous disease, probably doesn't exist in my opinion. And we're talking about APOL1 gene testing. So word's getting out.
Yeah, thanks to your efforts and others. This is great. So this starts to get at that provider piece. If you're going to get tested for it, you better know it. And Nichole, to your point, there are a variety of settings where it's still not happening, but there is some change. So the questions really are, how do we as a community, um, you know, increase the awareness to all of these different groups? I think if we segment the different sort of parts here, um, there's obviously going to be the most important is, like you said, Barry, having um, patients and community representatives with you from the beginning for any of your efforts, and real engagement. I think there's a healthcare side that hopefully people will take on, but it's good to see some of it trickling in. I guess if we sort of step back and say, this is your experience with Apollo is a wonderful example from maybe one end of the kidney disease continuum in the transplant setting. There's people early on, like Nichole's saying, might show up with some unclear symptoms. It might just be hypertension before they have kidney disease yet. That's really the primary care setting. And there's a role there also all everywhere in between, from being diagnosed with CKD to having advanced kidney disease, talking about um, kidney failure replacement options. That early part is important. How do we change that part of the ecosystem?
Uptal, just a couple of thoughts is, working for a very large healthcare system now, which has got healthcare facilities in the Midwest and through the Southeast and all of North Carolina. We're using an electronic medical record with best practice alerts to identify people with stage 3B CKD who have not yet been referred to nephrology, patients with late stage CKD who don't have an access or been referred for transplant. Best practice alerts can be tailored to say, if patient of African ancestry, consider APOL1 testing. Jewish populations should be tested for Tay-Sachs disease. All these things can be done through the EMR to some extent. But I turn on the TV and I see commercials now saying, do you want to end up in this chair in the dialysis clinic or in this chair on the beach? So I think there's going to be a key role for direct to consumer advertising about educating of APOL1 in patients who are told you have early CKD, you need to see a nephrologist, so the patient can go to their provider and say, should I get tested for that gene? I heard you need to know if you want to get into certain treatments. I can see a day when we go to PCPs in the EMR and patients on TV.
I think really quick, I like what you said about those commercials. But another thing is, Dr. Gillespie said, so last year, NephCure held a community type of event in DC, and it was terrific because the people who were involved and had, and were there weren't necessarily directly affected by kidney disease. They had dentists. There was a dentist I spoke with. There were community leaders. There were pastors. There were people who aren't directly affected by it, but people who are in touch with people who may be directly affected by it. So I think that was a big part of getting this information out, because they were able to take this information back to the community. One thing that I've noticed about my culture, my community, is we don't want to talk about things that we think we definitely may have. So if we say, hey, kidney disease, but if we try to change it a little bit and say, hey, maybe you have this gene, because if people think they have the gene, they automatically think, okay, I didn't have anything to do with this. This is just something that happened to me. So I think if we approach it from that standpoint, and I feel like that's what NephCure somewhat did, going to those communities and presenting it at that part. So if we go there, then you go back and you talk about kidney disease and you talk about other diseases that may affect that community. So I think that's the way to start. And also, like I always tell people, go to the HBCUs because you're getting the young people. And if you go to these HBCUs, I can guarantee you at least 75% of those children have a grandmother or aunt, a cousin who is on dialysis. And if you start there and let them take it home, then that's how we get this information disseminated and get it all wrapped up, in my opinion.
Thanks so much, Nichole. I just want to tie together another comment in the thread by Dr. Barbara Gillespie, highlighting Dr. Carol Horowitz's work. So she's a population health specialist at Mount Sinai and has done some wonderful studies of what could happen when you screen broadly and identify people who have the high risk variants. And her work has shown that you can really change behavior, not only patient behavior but also provider behavior, in doing some of the things what you can do. To Dr. Freedman's point, eventually therapies and being part of trials maybe to get those therapies approved sooner will be important. But short of that, doing the things we should be doing for anybody with early kidney disease, controlling blood pressure and putting people on medications that might be protective over the long term, can be helpful. And so that's something that's gets to that early phase of kidney disease where there can be an impact from greater awareness, right? So knowing that you have this these high risk variants and might have a higher risk of developing kidney disease. Again, I want to also highlight something Dr. Freedman said. Having the presence of those high risk variants doesn't imply that someone will develop kidney disease for sure, but your risk is much higher than it would be without it. So that's a nice example from the early segment. The other part is an earlier comment from one of our participants from 23andMe, really highlighting that one of the ways they've been able to engage people is by having a chronic kidney disease report for people. So if people go and get tested, so this is maybe building on the direct to consumer suggestion Dr. Freedman had. If patients are made aware of this risk allele and that they can be empowered to do something about it, one of the first things they'll do is obviously get tested. There are a variety of different ways to get tested, and we'll dive into that deeper in our second webinar. But having a report to help make sense of that information is an important part of it. And we'll talk about all of the counseling that is probably necessary that there's some barriers to. Maybe thinking about sort of the next step, if we just sort of think about from your perspective, what are the biggest, and this is also highlighted in the chat, what are the biggest public health policy barriers to raising greater awareness about APOL1?
Just a couple of comments, and I know testing is a future effort, but one thing Apollo has done with our educational profile, our infographics in an understandable way, is to make sure people know the risks of getting their result back. There are risks to knowing your result. And, the bottom line is you don't have to have your result back in Apollo. You must want it. And I just have concerns with broadly sharing data with people without their understanding that if they march into their doctor's office and say, hey, I did this testing, I've got the APOL1 high-risk genotype, and the doctor types that into their clinic visit that day, suddenly it's in the electronic medical record. Apollo has bent over backwards to not let that happen. The only way that can happen is if an informed participant, understanding that if they tell somebody in the medical community it could end up in their EMR, does it. But it's going to be directly delivered by mail or personal report, hand letter, not part of the medical record to the participants in Apollo, and I worry about that if it's not. So, there are risks to letting others know your genotype if you're high risk. The other thing I would just say is we test pretty much all babies of African ancestry for sickle cell variants at birth around the nation. and 8% of the African-American population have sickle cell trait or sickle cell disease. It's actually 7.8% have trait, 0.2% disease. Now, that's a Mendelian disorder. If you have two copies, you're going to get sickle cell disease, different than APOL1. But, you know, more than half, 52% of African Americans have APOL1 risk variants, and we don't have a testing plan in place. There's a lot of concerns with the plan, but that's something that I think, Uptal, we have to talk about in the future.
That's a great point. So, you know, we mentioned one of the goals was ICD-10 diagnosis codes becoming available, and there's an active effort. You raise something that, you know, goes even sooner to broad population screening that could be part of newborn panels, and so that's an important effort that, you know, would love to hear more about in the future. Obviously, complex in many ways from a policy perspective. But something that could be quite important. And you raise a nice parallel of sickle cell, and the numbers there certainly support us considering that for APOL1. I think a couple other comments I'll get to before we sort of shift gears is somebody suggested we think about this in the value-based care environment where identifying people and risk stratifying patients earlier could really impact awareness and education. Maybe Nichole, can you speak to like how you see that from the patient perspective? Would that be something that would provide value and increase the value of care for patients? How could we, as a community, enable that?
Oh yeah, I definitely think early awareness, will help. As Dr. Freedman said, one of the biggest things I've been, trying to say is why aren't we testing babies for this gene? I know, as you stated, they test for sickle cell, and I've also been told that Asian children are tested for IgA. So why can't we start testing Black babies? Yes, there's nothing that we can do at this point. However, we can maybe change lifestyles. A good example of that is Glenda Roberts. Glenda Roberts was told about her kidney disease early on in life, and she was able to put off actual failure for about 40 years by changing her lifestyle. So that's the perfect example. Before, I wasn't necessarily the person who believed in that until I met her. And I understand that learning earlier can make you change your lifestyle.
Great, thanks. That's a powerful example. And Glenda's been adding a bunch of nice comments here, highlighting the role of KPMP, giving study participants the option to be included or excluding based on the presence of gene variants in their EMR. So giving people information directly is, very important, but it has to be done rightly, like Dr. Freedman described. There are definitely risks of that information. We're going to dive more into, I see a few comments related to testing, and that's going to be its own topic next time. So with that, maybe I will thank our panelists. Nichole, thank you so much for sharing your personal stories and your insights from your Apollo experience. And Dr. Freedman, always fighting the good fight. Appreciate your ability to bring the science together with the impact that you and others are making, and highlighting still the work yet to be done. So that's a good maybe segue into, if I can have the final slides pulled up, some final thoughts here. So next slide. So one of the really nice things that was highlighted last year. So at our annual meeting that we had in September of 2023, we had the pleasure of having Commissioner Califf join, and he was struck by a lot of the various, a lot of the programs and projects and efforts of KHI. But this was something he tweeted after the meeting, and as a follow-up, he just wanted to share that, look, he sees, and the agency recognizes that genetically mediated kidney diseases are increasingly being recognized, and there are a number of new therapies being developed. And the FDA is a willing partner and ready for evaluating those therapies, and quite enthusiastically awaiting them. I think that highlights that in developing treatments, we see a partner that's heavily engaged, and that's probably not going to be the barrier. Next slide. I think what is going to be the barrier of having these new therapies reach people are the following challenges that we have to solve together. One, raising awareness. Two, next time we'll dive into genetic testing. And then until we have those treatments available, having people be identified and decide whether or not participating in a trial is the right decision for them. There's a number of different barriers related to that. Eventually, what we want is, once those therapies are approved, all of this foundational work will hopefully help everybody decide whether or not the various treatments that make it across and show that they're safe and effective, people can be empowered to make the decisions about which ones are right for them and which ones might be the best for them to use. Next slide. So with that, I want to thank everybody for joining today. Encourage everybody to continue to interact. I think we might need to figure out ways to continue the conversation as a community, and we're open to suggestions. So in the final minutes here, if you have any, we'd love to have them. Also want to highlight that the second of this series of webinars that will focus on how to increase access and awareness of genetic testing, but also the counseling that's an important part of sharing any of those results, will occur on August 6th. So please check out our website to sign up for that. Hopefully everybody who joined today will get an email as well. And then finally, the third webinar will focus on empowering patients to make informed decisions regarding whether or not participating in a clinical trial is the right decision for them, and what are some of the factors and considerations to think about. That'll happen on September 24th. So I want to thank the entire KHI team, particularly Cecia and the Ripple Effect team and Shay for helping behind the scenes. You didn't get to see them today, but all of them, Abby, Lee, others, have been tremendously helpful in setting this up. And want to again thank our phenomenal presenters and panelists, Nichole Jefferson and Dr. Barry Freedman. With that, wish you all a wonderful day.